All right. Good morning, everyone. It is 7 a.m. and we are going to start bright and early and on time. And I have the great pleasure to introduce two speakers today, Dr. Terry Grebe and Dr. Vinod Narayanan. And these are our, OG leaders in genetics and child neurology. Um, they were sort of the neurogenetics before neurogenetics was even a term. Now it's a wonderful thing. So Dr. Grebe, many people know her. She is a clinical geneticist here in the Division of Genetics and Metabolism at Phoenix Children's, and she's served on many teams, the Craniofacial Center team, multiple specialty clinics. She focuses on craniofacial and neurogenetic disorders, including autism and epilepsy, and she is a fierce advocate for all of these children with complex diseases and their families, and especially has interest in Rett syndrome. And so I've been very excited that she's going to join us, along with Dr. Vinod Narayanan, who is a child neurologist with special interest in the genetic basis of neurological disease. And he has been at Barrow Neurological Institute after he was on faculty for many years at University of Pittsburgh. And he founded the pediatric neurology and neurogenetics practice, his neurology and neurogenetics practice in 2011. And he serves as medical director at the Center for Rare Childhood Disorders at TGen. And he also has been monumentally important in learning more about Rett syndrome. And so I'm very excited to have these two people. And I will stop talking and start by letting Dr. Grebe and Dr. Narayanan take it away. Thank you.
Thank you, and good morning, everyone. It's a pleasure to be here. I want to thank Dr. Lewis for inviting me to speak to you today about multidisciplinary care for Rett syndrome, and I'm very happy to share this talk with my friend and colleague, Dr. Narayanan. These are our educational objectives. I'm going to speak to the first three, which are mainly clinical, and then turn it over to Dr. Narayanan to talk about the latest developments and new treatments and research in Rett syndrome. Our disclosures are that we are genetics advisors for Acadia Pharmaceuticals. One of the most common reasons for referrals to both genetics clinic and neurology clinic is the child with developmental delay and a concern for neurodevelopmental disorders. So just how common are they? Well, among the approximately 20,000 protein coding genes in the human genome, more than 1,300 causative genes and 1,100 candidate genes have been implicated. And that number is rising as of 2025. I've really seen in my practice an explosion of new disorders over the last 5 or so years. And I can estimate I see one new gene approximately every 1 to 2 weeks in my clinic. So when we consider both established and proposed disorders, estimates suggest that there's over 3,000 different potential genetic neurodevelopmental disorders. And among these, Rett syndrome was the first described, likely the most common and the best studied. So Rett syndrome was first described by Dr. Andreas Rett, an Austrian neurologist and author, who in 1966 published a paper on 22 girls that he followed who developed a very distinctive and progressive neurologic disorder after a period of apparently normal early development. So he described these girls in detail who developed developmental stagnation and regression after 6 to 18 months of age, followed by loss of motor skills and language skills and the emergence of certain characteristic features. He also noted the development of seizures in the majority of his patients, and he described the progressive nature of this disorder in 4 distinctive clinical stages, which I'll go through. So how common is Rett syndrome? Well, the worldwide prevalence is estimated at approximately 1 in 10 to 23,000 female births. So in Arizona, we currently, as of 2020, had 360,000 births. So we may have as many as 18 children born each year with Rett syndrome. I know they're out there, and I think some maybe are going undiagnosed. A systematic review estimated a pooled prevalence at 7.1 per 100,000 females. So we know that because Rett syndrome is X-linked, it almost exclusively affects females. But not always. There are some very rare males with Rett syndrome, and I'll talk about them in a bit. They typically present with much more severe manifestations. And finally, there's several phenotypes of Rett syndrome, which we now call MECP2 related disorders, and I'll talk about them briefly as well. This slide shows the Rett syndrome diagnostic criteria that have been described and revised. On the left, you see the main criteria for classic or typical Rett syndrome. So there must first be that short period of normal development, followed by a period of regression, followed by recovery or stabilization. The main criteria are partial or complete loss of acquired purposeful hand skills, partial or complete loss of spoken language, gait abnormalities, and stereotypic hand movements. And these include most classically hand washing or hand wringing, but I have patients who do hand clasping, some finger crossing, and a lot of mouthing of their fingers. So atypical Rett syndrome, the other phenotype, is similar. It also follows a period of normal development, followed by regression, and then followed by recovery or stabilization. This diagnosis requires 2 of the 4 main criteria on the left, plus 5 of 11 of these supportive criteria, many of which are very classic for Rett syndrome. So those include breathing disturbances while awake, which is really striking when they're in clinic with you, bruxism, teeth grinding while awake, sleep disorders, hypotonia, peripheral vasomotor disturbances, scoliosis and/or kyphosis, growth retardation, short stature, small cold hands and feet, inappropriate, sometimes prolonged laughing or screaming spells, diminished response to pain, and a very specific behavior to Rett syndrome called eye pointing. And this is an intense form of eye communication where the patient, the individual, stares intently at a person or object that they want. It's a very purposeful, nonverbal form of communication, which really indicates that the individual's cognitive function is higher than their expressive language abilities. How common are these classic features? As you can see on this slide, the vast majority in classic Rett syndrome occur in over 99% of individuals, with the exception of deceleration of head growth, still high in 80%, and seizures in 60 to 80%. As I said, Dr. Rett described a timeline of progression, which he divided into 4 stages that still applies. So I'd like to go through those for a minute. Starting on the left, there must be a period of normal prenatal and perinatal development up to about 6 months of age. And then stage 1, the early onset stage, goes from about 6 months to 18 months. This is characterized by slowing of head growth with microcephaly, hypotonia, and delayed development. Stage 2 is called the rapid deterioration stage, and this goes from about 18 months to 4 years. And during this stage, there's loss of motor and communication skills. The individuals become nonverbal. That's when they develop these stereotypic hand movements and breathing irregularities. Seizures are likely to start at this time. Microcephaly worsens, and they may have features of autism. Then in stage 3, between age 4 and 10 years, there might be actually a period of stabilization. It's called the pseudo-stationary phase, and there's actually potential for some improvement in cognitive and social skills. Scoliosis can rapidly worsen during this phase. Seizures may continue or start, and autonomic dysfunction might appear. And then the last stage, the late motor deterioration stage, begins at about 10 years and can last either several years to decades. And it's during this phase that the patient really becomes much more debilitated. They're likely eventually to lose ambulation and become wheelchair bound. They may have dystonia and Parkinsonian features. So I do want to briefly mention a couple other variant types of Rett syndrome, which we now call MECP2 related disorders. It's important to mention these because these may be conditions you see where you weren't initially suspecting Rett syndrome as a diagnosis. So the first is variant Rett syndrome. So females with this can have a very broad spectrum of symptoms which overlap those of classic Rett syndrome. So at the mild end, they may have less regression, and intellectual disability is less severe, and they may have some preserved speech. While at the severe end, they might have developmental delay beginning very early in infancy, hypotonia, and even infantile spasms. Then there are some girls with MECP2 variants who have only mild learning disabilities. They may have no hand stereotypies or regression. And this we feel is due to a favorable skewing of X inactivation. If you remember with two X's, one is inactivated. So instead of the 50-50, it might be skewed toward the normal X. And finally, some MECP2 pathogenic variants have been identified in individuals with just autism and schizophrenia. Now, historically, Rett syndrome in males was felt to be incompatible with life, but we do know that there are some males with Rett syndrome, although it's extremely rare. Survival is improved if the male has somatic mosaicism, i.e. the mutation not in all the cells of the body or the germline, or they have a sex chromosome abnormality such as Klinefelter, where there's an extra copy of the X chromosome. But typically, males with Rett syndrome are going to present with a very severe neonatal encephalopathy. They may be normal at birth, but there will be a really relentless clinical course with severe seizures, breathing abnormalities, and typically death before age 2 years. And finally, one unique phenotype called X-linked intellectual disability and pyramidal signs, Parkinsonism, and macroorchidism syndrome is caused by one specific variant in MECP2. I've never seen that one that I know of. And I do want to mention an allelic disorder, which is quite distinct from Rett syndrome, and that's called MECP2 duplication syndrome. So not to be confused with Rett syndrome. This is a condition that affects males who have an extra copy or duplication of MECP2. And sometimes they have a much larger visible duplication on XQ28, the chromosome. And in that case, they have a much poorer prognosis. So this syndrome is a bit different. Males present typically in early infancy at birth with hypotonia, delayed development, severe intellectual disability. They might be minimally verbal, but a characteristic is they develop progressive spasticity, so might be diagnosed with cerebral palsy. They are at very high risk for recurrent respiratory infections, which is a frequent cause of death before age 25, and they also develop seizures. This little guy here on the left is actually one of my patients here at PCH. I'm happy to report he's doing very well at age 6 years. This is his lovely mom who lobbied the legislature in Arizona and was able to have the governor announce a MECP2 duplication syndrome awareness day. So she's been very active for her son. I wanted to spend a few minutes talking about the discoveries in Rett syndrome. So as I said, the syndrome was first described in 1966, but the protein, the MECP2 protein, was identified in 1992. It's called the methyl CpG binding protein 2, and it's a nuclear chromatin-bound protein that binds specifically to methylated DNA. Here's a little model of the protein in green bound to double-stranded DNA. Down here, I'm showing you the components of the protein that I know Dr. Narayanan will talk about as well. In blue, there's the N-terminal domain, and at the other end, the C-terminal domain. The active parts of the protein are here in green, the methyl CpG binding domain. This is a less functional area, the intervening domain, and then the transcription repression domain is also very important. So there are two main transcripts of the MECP2 protein that lead to two isoforms, 1 and 2. They result from alternative splicing. Isoform 1 includes exons 1, 3, and 4, while isoform 2 includes exons 2, 3, and 4. So the one that's most prevalent in the brain is the first isoform, which represents more than 90% of the MECP2 protein. And we do know, of course, that the protein is most highly expressed in neurons and it plays critical roles in brain function and development. Just a brief diagram here to show you kind of the different roles MECP2 plays in the cells in the brain. We knew initially that MECP2 is involved in transcriptional repression. It binds methylated CpG dinucleotides and then recruits various suppressor complexes such as MSyn3A and HDACs, whereupon it condenses the nucleosomes to this condensed formation, which prevents RNA polymerase II here from binding and then blocks transcription. But we also know that MECP2 is involved in transcriptional activation in other settings. So in this role, it binds to 5-hydroxymethylcytosine here and recruits different activators, including the Grebe protein and various activators, and then modifies the nucleosomes into the open configuration you can see here so that RNA polymerase can bind and transcription can proceed. So what's interesting, I think, about this protein is just that it involves many functions and even beyond a DNA methylation, but it has this dual functionality of both activator and repressor, which is really context dependent, and it varies with chromatin modifications and the cellular environment. So I'm sure Dr. Narayanan will talk more about its role in the brain and how therapy can correct deficiencies. So it wasn't until 7 years after the protein was discovered in 1999 that Dr. Huda Zogby and her colleagues discovered that mutations in MECP2 cause Rett syndrome. And I remember being at that meeting when it was discovered. And this was published in Nature Genetics. So she and her team used systematic screening to identify MECP2 mutations in 21 sporadic cases, and they found 5 mutations. And they included multiple types of mutations, including frameshift, nonsense, and missense variants. Her study also identified, interestingly, a pair of affected half-sisters, which suggested that their mother had germline mosaicism. This study was really groundbreaking because it revealed that Rett syndrome results from abnormal epigenetic regulation, and it was the first of its kind. We now know of many other conditions with similar mechanisms. So I want to mention just briefly a few genotype-phenotype correlations, but to state, of course, that most pathogenic variants are de novo, so new mutations in the affected child. And for MECP2, pathogenic variants are loss of function, which is opposite of the MECP2 duplication syndrome that I mentioned. There have been more than 620 mutations identified to date, and most of them occur in the active region in the methyl binding domain, but some do occur in the transcriptional repression domain. And there are a large number of frameshift variants at the end of the protein in the C-terminal domain. This is a busy table, but it just wanted to illustrate that 5 of the most common recurrent pathogenic variants, as well as several others that cause milder phenotypes and non-classic Rett syndrome, and one that's been described in some males with ID and features of MECP2 disorder. But again, sequencing will allow us to identify any of the 620 or more mutations. This is just, again, a diagram of the MECP2 protein showing you the hotspots for the mutations here in the methyl CpG binding domain and the transcriptional repression domain. Okay, how should we test for Rett syndrome? Well, there's multiple testing options available. If you're absolutely sure your patient fits the classic phenotype of Rett syndrome, you can just do sequencing of MECP2, which would detect all different types of variants, and deletion testing can also be done. This is offered, of course, by multiple labs, including our own Phoenix Children's Genomics Lab, as well as outside labs. But more typically, we do multi-gene panels because there are several other conditions that overlap with Rett syndrome. So there are epilepsy panels offered here at PCH, as well as outside labs, panels called Rett-Angelman syndrome panels because of the overlap there. But if your patient really has a phenotype that resembles Rett syndrome, but not classically, and overlaps with other disorders that are characterized by intellectual disability or neonatal encephalopathy, and again, 3,000 of them, it's better to do whole genome or whole exome sequencing. Right now, we're sending ours to GeneDx, but there are many labs all over that do this, and our genomics lab is offering that. So basically, multiple labs around the country can offer this for you. So how is Rett syndrome inherited? Almost 100% are due to de novo pathogenic variants. So as I said, new mutations. But even still, we do recommend testing both parents for the female proband And if we have a male, testing is recommended for the mother. And as I mentioned before, occasionally a mother may have germline mosaicism or have favorably skewed X inactivation. So she might be mildly or minimally or completely unaffected and unaware that she has the mutation. So if parental testing is negative, we assume then there's either a de novo variant in the proband or germline mosaicism in the parent. And we typically will counsel for those families that their recurrence risk is approximately 1%. And for couples who are still anxious, which is understandable, prenatal testing for Rett and pre-implantation genetic testing with IVF is possible for all MECP2 related disorders. So just quickly, what if it's not Rett syndrome? A few conditions to keep in mind in your differential. I've shown here. So on the left, this little guy has Angelman syndrome. Of course, you're all familiar with that. You know, in the early months, it is difficult to distinguish Angelman from Rett syndrome, although Angelman, of course, occurs frequently in males. They have intellectual disability, severe speech impairment with almost no language development. They have that very happy demeanor, but they have a gait ataxia and even an upper truncal ataxia with some tremulousness. That's not typical for Rett syndrome. Their seizures are often earlier at 6 months of age. And for the epileptologists, I know there's a characteristic EEG pattern in Angelman syndrome that's somewhat specific to the disorder. The most typical finding is high amplitude rhythmic delta activity, 1 to 3 hertz, with a bifrontal predominance. And I'm not an epileptologist, so don't ask me about that. Also to keep in mind is FOXG1, which is often on the Rett panels. This is sometimes called congenital Rett syndrome. These children are all de novo mutations. They're more severely affected than Rett, typically don't learn to sit or walk, have severe intellectual disability, very severe seizures, spasticity, and movement disorders. They have multifocal spike in waves and may have delayed myelination or a simple gyro pattern on their brain MRI. And then finally, CDKL5 deficiency also is in that differential. It's an early infantile epileptic encephalopathy, also X-linked. They also have very early onset severe seizures that are difficult to control. Some of them have some minor dysmorphic features. This is a little cutie here showing the broad forehead and large eyes. Okay, for the last part of my talk, I'm going to focus on the appropriate medical management for Rett syndrome. So there are many guidelines published in the genetics literature, and I'm sure in the neurology literature, but probably the most comprehensive guidelines have been published by the International Rett Syndrome Foundation, shown here. This is the cover of their book. So I'm going to go through what initial evaluations should be done for a child with Rett syndrome after diagnosis. And it is a very multi-system disorder, as I've mentioned. So there are a number of evaluations that should be done initially. Goes without speaking that a neurologic evaluation should be your initial appointment. It should include a brain MRI and consideration of an EEG and video monitoring if seizures are a concern, which they likely will be. A developmental pediatrics assessment is also critical at any age to include motor, adaptive, cognitive, and speech skills, and they should be referred for early intervention as soon as possible. A neuropsychiatric eval is also really helpful for children aged greater than 12 months because they have a frequent sleep disturbances, anxiety, ADHD, and many have findings of autism. Due to the hypotonia, musculoskeletal issues are quite common, so orthopedics should be involved, as well as physical medicine and rehab, and our therapy teams. Many develop scoliosis, so they need monitoring for that. They really benefit from a lot of mobility training and physical therapy, and many will need adaptive devices. So the longer they can remain ambulatory, the better the prognosis. Our GI partners are crucial for managing Rett syndrome. Individuals with this have a very high likelihood of having GI dysmotility, which can result in aspiration and feeding issues. So they should have a feeding eval. Nutrition is a great concern. They're usually underweight. Constipation is pretty classic, as well as reflux, and many later on will need a G-tube placement. I mentioned breathing abnormalities early on, so pulmonology is a indicated referral to analyze for abnormalities of breathing regularity. Overnight sleep studies also should typically be done. Sleep medicine is also beneficial to assess both nighttime breathing and sleep disorders, which are common. And every girl with Rett syndrome should have an EKG to assess for prolonged QT syndrome, which is a known risk factor for early death. And that should be repeated regularly every few years. Bone density studies are important, especially later when they become non-ambulatory, to assess for osteopenia. I refer all my patients to ophthalmology. There's a higher frequency of vision problems, including low vision and strabismus in Rett syndrome. And then a yearly audiology evaluation should also be done. And finally, attention should be paid to the skin, as they tend to have decreased perfusion of their hands and feet, which goes along with a lot of autonomic abnormalities in this cohort. So what treatments are there specifically for Rett syndrome? Starting with seizure management, there is no single Rett syndrome specific anti-epileptic drug, but valproate, carbamazepine, and lamotrigine are frequently the first line drugs used and are typically effective. But of course, drug selection should be guided by the patient's age and seizure onset and timing. But again, I'll stress that approximately 60 to 80% of girls with Rett syndrome will develop seizures, typically around age 4 years. For behavior management, those crying spells and anxiety and agitation that we see in a lot of the girls, low-dose risperidone or SSRIs have been somewhat successful. Our sleep medicine doctors are very helpful in treating sleep disorders. Several that have been looked at, but really studies are early on, include gabapentin, clonidine, trazodone, and mirtazapine. I will say that antihistamines and benzos should be used cautiously due to potential side effects in these girls. And then trofinetide has been shown to help somewhat in nighttime behaviors, but it hasn't been specifically approved for sleep. I did mention the risk of cardiac arrhythmias. So VTAC can arise from long QT. And interestingly, sodium channel blockers such as phenytoin and others have really shown significant benefit in treating this symptom in Rett syndrome over the usual use of beta blockers. Avoidance of QT prolonging drugs is really essential. And there have been some small studies looking at acetyl L-carnitine. For the breathing abnormalities, which are quite distressing when the child is awake, we do know that they result from abnormal GABAergic inhibition and serotonergic dysfunction in the brainstem. Several of our patients, we've used acetazolamide off-label, but it really hasn't shown too much efficacy. So more recent studies are looking at serotonergic agents, specifically 5-HT1A receptor agonists and SSRIs, as well as GABAergic modulators. So I'm hoping we'll have more progress in that area. And then, as I mentioned, GI problems are extremely common, and this is probably the most common non-neurologic feature of Rett syndrome in about 92% of our girls. There is no specific treatment. They do need reflux medications for frequent vomiting. They may need G-tube for dysphagia, feeding therapy, and standard constipation treatments. And finally, targeted MECP2 treatments, I'm going to leave to Dr. Narayanan. So because Rett syndrome is a multi-system disorder, it really requires a multidisciplinary team. And this team is typically led by neurology in close partnership with developmental pediatrics, sometimes genetics, physical medicine and rehab. GI and pulmonology are close partners, as are our therapy team, our psychiatry and psychology teams. And I want to mention research too. It's very important for the treatment of Rett syndrome, both the natural history study and keeping abreast of all the new treatments coming down the road. So just wrapping up, what support do we have for families with Rett syndrome? Well, we have great specialists here at PCH, and I think I'm hopefully safe in saying we are working on starting a Rett syndrome multidisciplinary clinic here to be led by Dr. Angapan, working with Dr. Narayanan, Dr. Raz from developmental pediatrics, and myself. We are going to be on the team, and we have recruited some of our GI and pulmonology and physical and medicine and rehab partners. But we did learn that some of our Phoenix families are traveling up to Colorado to the University of Colorado's International Rett Syndrome Center of Excellence, and there is a support group up there. So we hope to bring them back to Arizona as soon as possible. Overall, the largest support group for families with Rett syndrome is the International Rett Syndrome Foundation, or IRSF, which is a very large, wonderful organization that provides education, support, and supports and funds research for Rett syndrome. So I'll just leave you with the thought that Rett syndrome is not just a pediatric disorder, but it's a lifelong condition. The Rett syndrome natural history study, which ran from 2006 to 2015 and followed almost 1,200 individuals with Rett syndrome, found that among the 51 deaths in that cohort, the age range of death was from 3.9 to 66.6 years. So survival into the fifth decade is really typical now, with recent data showing more than 70% survival at 45 years of age with classic and atypical Rett syndrome. So this is a very dramatic improvement from Dr. Rett's original cohort in 1966, which had only a 21% survival to age 25. So cause of death in Rett syndrome is typically cardiorespiratory compromise and often pneumonia. I mentioned cardiac arrhythmias, particularly VTAC associated with long QT, is another risk factor for sudden death. And there's several modifiable, so treatable risk factors that influence survival. One is disease severity, but second is ambulation status. So the longer we can continue ambulatory status for our patients, the better survival. Good nutrition and weight and seizure control. They're all associated with increased mortality if they are not well treated. So I'll say that multidisciplinary care for Rett syndrome with emphasis on nutrition, weight gaining, maintaining ambulation as long as possible, seizure control, and also surgical correction of scoliosis have contributed to the extended life expectancy. So this suggests that we can continue to improve care for our patients with Rett syndrome over the course of their lifetime, and also stresses the need, I should say, for our transition program with our adult medicine partners. So finally, this is Anne Charlotte. She's 73 years old and lives in Sweden and believed to be the oldest patient living with Rett syndrome. So I'm over time. I'll stop there and turn it over to my friend, Dr. Narayanan. Thank you. I hope.
Okay, now PowerPoint, share, and okay, how does that look okay to everybody?
Yes.
Okay, great. First of all, thank you, Kara and Terry, for inviting me to present what I've learned over the last 40 years about Rett syndrome. I'll skip over this because Terry already mentioned this. Some of our laboratory work has been supported by really intramural donations from the Dorrance Foundation and from TGen. And we were recently successful in getting one of our projects funded by the NIH. And I have served as a consultant to Acadia Pharmaceuticals on their genetics advisory board. So I thought I would put this in at the beginning rather than waiting till the end, just in case we are short of time. And I want to acknowledge almost 40 years of collaborative work with Dr. Sakubai Naidu, who is a pioneer in the field of Rett syndrome. I met her in 1987 when she came to our lab when I was working at Gian Tennecourt at Hopkins. She wanted to isolate mitochondrial DNA from brain tissue of postmortem tissues from patients with Rett syndrome to look for mitochondrial DNA mutations. And I'd like to also acknowledge Dr. Sampath Rangasamy, my colleague who's here now at ASU. He worked with me at TGen and at the Barrow from 2014 till now, who was a key person in all of our Rett syndrome studies. And most recently, collaboration with Dr. Chatterjee, who's at the Beckman Research Institute at City of Hope, and her team that includes Aravind, who used to be in our lab, and Swati, who has been there. So I'll start by reviewing a few things, some things that Dr. Grebe has already mentioned. By the way, what I'm going to do today is really focus on kind of two things. One is a little bit of the biology and science that led to the identification of IGF-1, insulin-like growth factor 1, as a key kind of signaling pathway. And that led to the FDA approval for trofinetide. The second is to review preclinical studies on gene therapy, which led to the two human clinical trials that are ongoing right now with a gene replacement therapy product. And lastly, a few slides about our own work on gene editing. So this cartoon, which you've seen already before, shows a diagram of what MECP2 gene looks like. There are 4 exons and 2 isoforms generated by alternative splicing. And as Terry had already shown you, I think maybe my pointer will work. 99% of the variants that are seen in human cases of Rett syndrome are localized to these coding regions of exon 3 and 4. And in genomic DNA distances, that accounts for less than 2.5 kilobase pairs of DNA, which means that whole thing can fit into the AAV virus as a single-stranded genome. Here, again, something that Terry had already showed you, the key domains. And, a lot of work has been done on the biology of Rett syndrome, but still comes down to 2 areas: the methyl binding domain, or MBD, which is the part of the protein that recognizes and binds to methylated CG dinucleotides, as well as other methylated cytosine residues. And then the transcriptional repressor domain that binds to protein complexes that are involved in transcription modulation. Down here at the bottom, I've shown a picture taken out of a 2001 paper by Adrian Bird. Adrian Bird was the one who first identified MECP2 way before it was linked to Rett syndrome. And this shows the survival curves in a mouse model in which MECP2 has been knocked out. So exon 3 and 4 were deleted. And you can see this is the survival of the knockout mice. This is the wild type mouse. And roughly about 9 weeks is how long a male animal that carries the null allele lives. All of the early studies, once people started making mouse models, were all geared towards phenotype characterization. Did it reproduce what we see in humans? And what does this teach us about the biology of MECP2 and its function? So that was really the focus for a very, very long time. Knockouts, knock-ins, because of course none of our human patients have a deletion of exon 3 and 4. Most of the mutations are either point mutations leading to truncation, missense mutations, or C-terminal deletions. But the null mouse was a very, very useful model that led to a lot of insight on the biology. But the key, I would say, here is really a landmark discovery that came out of, again, from Adrian Bird's lab in Edinburgh, 2007 paper demonstrating that if you were, through, again, genetic technology, if you're able to reactivate expression of MECP2 in a null mouse model, that you could rescue the phenotype. That means survival would be close to normal, and many of the symptoms, the motor impairment, the breathing issues, could all be corrected, and also that the cellular pathology, the neuronal, the size of the neurons, the dendritic arborization, all of the pathology was also corrected in these mice, even when you reactivated the gene at a fairly late stage in disease. So this was really amazing because it gave us hope that you could really treat this condition, that the effect of the mutation was not a permanent thing, that it did not, it was not irreversible. So that set us off to trying to find treatments, as well as genetic and non-genetic, small molecule therapies. So there are a lot of things that are challenges for Rett syndrome therapy development. And first is based on what we knew about molecular mechanisms. MECP2 as a transcriptional modulator is modulating the activity of thousands of genes. This is in contrast to a condition like tuberous sclerosis, where there's a single pathway. The mTOR pathway is a key pathway in TSC, so you could potentially tackle that with small molecules. Here you have to somehow restore expression to normal of thousands of genes, so a difficult task. The second problem is that MECP2 is a highly regulated molecule itself. Its expression is controlled, and its structure is altered by phosphorylation and other post-translational modifications. And so these transcriptional modulation complexes are assembled in a very dynamic fashion. And this is very important for learning and synaptic plasticity. And so that tells you why MECP2 is critical for normal brain development. So the dynamic aspect of it has to be tackled. The third thing, which is really the major problem, is what we call the Goldilocks problem, gene dosage sensitivity. And we know now from both transgenic mouse models where 1.5 to 2 times gene dosage can cause a neurological syndrome, and then the identification of the MECP2 duplication syndrome, again confirmed that this is really a human disease. Too much is as bad as too little. And the major problem is, of course, 99% of our patients are female, and females, because of the pattern of X inactivation, are mosaic. So that means they have normal cells and mutant cells in their brain, and you would like to somehow target only the mutant cells without disturbing the normal cells, and that is a big challenge. Now, years and years of studies of biological mechanisms, the thousands of genes that are altered, led to focus on two things. One is brain-derived neurotrophic factor, a growth factor that's very important in brain development and plasticity. Was one of the first things that was discovered to be modulated by MECP2, and increasing expression of BDNF can rescue the phenotype in MECP2 null mice. The second thing is IGF-1, which also works through similar signaling pathways, AKT, PI3 kinase, AKT, and mTOR, also promotes neuronal development and synaptic maturation. BDNF does not cross the blood-brain barrier, and so was not possible to develop as a therapeutic agent, although there are efforts at identifying small molecule ligands that would activate BDNF. So using kind of molecular mechanism-based strategies, people have tried many, many things, including TrkB ligands, fingolimod, which is used in multiple sclerosis, known to increase BDNF levels, neurotransmitter receptors, and of course, genetic therapy, small molecules that could target specific subclasses of mutations, and maybe even reactivation of the silent X chromosome, which is a strategy that has been tried in cellular and mouse models. But the focus really is on IGF-1, which has been developed into an FDA-approved drug right now. So how did this come about? So IGF-1 was known to be a very important molecule in the development of cortical synaptic plasticity. This is work from many, many years ago from basic neuroscientists who were studying uh, ocular dominance cortical plasticity in a mouse model. And one of the genes that showed up were IGF and IGF binding proteins. And in a completely different pathway of investigation in people who are looking at genes by RNA sequencing that were affected by MECP2 mutation, they found that IGF binding proteins were also regulated by MECP2. So putting these two things together, there's a group in Boston, the laboratory of Dr. Mrganka Sur, who published this paper in 2009, showing that in a MECP2 null model, they used the exon 3 deletion model, that you could treat with the active N-terminal tripeptide. This is the IGF-1 gets cleaved off from a pro molecule into the N-terminal tripeptide and the rest of the molecule. And the IGF tripeptide is active in the cortical plasticity model. And they found that if you could treat these animals to rescue the phenotype in the MECP2 null mouse, motor function, survival, cellular pathology, as well as physiology. Of course, IGF-1 is already FDA approved for treating endocrine disorders and growth failures. And so this was a natural thing to test. And it turned out that it was safe, but did not have any efficacy in placebo-controlled crossover studies in humans. And the problem also is that the IGF-1 tripeptide, this is the glycine proline glutamate tripeptide, has to be given parenterally. So in mice, you can give it intraperitoneally. In humans, you can give it IV, but it has an extremely short half-life, lasting only a couple of minutes. So for therapy development, this was altered to get a synthetic form of this tripeptide, which is what is now called trofinetide. They added an alpha-methyl group to the prolyl group, and this improved the stability, the half-life in the terms of hours, and it's also orally bioavailable. So you could have an oral drug. And for many years, this drug was being tested in many different neurodevelopmental disorders, including brain injury and stroke. So this was tested between 2017 and 2019 in safety trials in Rett syndrome, led by a group that included Daniel Glaze, Alan Percy, and Jeff Newell. And they found that it was safe to use in various doses. A dose escalation study suggested that even up to 200 milligrams per kilogram BID was tolerated in patients with Rett syndrome, with the main side effects being diarrhea and vomiting. And in these preliminary studies, at the highest dose, there was evidence of some improvement in the phenotype as measured by a caregiver rating scale called the RSBQ, and the clinician's gauge of clinical improvement, the CGI-I. This led to a phase 3 study that was gone between, I think, 2019 to 2023. Our own clinic at TGen was one of the sites for this study. And so we were participants in this study. And based on this, 187 patients were recruited. And the primary endpoints were these two behavioral measures, RSBQ and CGI-I. And based on the improvement in the score, as well as for RSBQ and CGI, it did get approved by the FDA. The only thing is that I would say, there was a drop-off in the number of patients that went on into the open label studies, both the LILAC-1 and the LILAC-2 studies. So I think I'm going to go a little bit faster because we're running out of time. I like to show this picture because this is a female mouse in which, this is a hippocampus dentate gyrus in a mouse where the paternal X has been marked with green and the maternal mutant X, mutation-carrying X, is not marked with green. Shows you in graphic pattern the X inactivation in the brain. So in the last few minutes, I'm going to talk about the gene replacement strategies. These are the problems, especially the Goldilocks problem. It needs to be present throughout the brain. It has to be lifelong. It's not enough to just have this gene active for a few years because adults need this too. From between 2013 and 2024, there were a number of preclinical gene therapy studies in mouse models. Almost all of them started with the male null animal because it eliminates the confounding factor of X inactivation. And then these were also tested in the females. And the uniform finding was liver toxicity when you give it systemically. This was less of a problem when the vector was given intrathecally or into the cerebral ventricle. And then overexpression toxicity in both female mice and in wild-type animals. So this is a big problem. And these two labs, one led by Stephen Gray and the other one by Stuart Cobb, were trying to get around this problem by introducing regulatory elements into their vector. And then another, Stuart Cobb's lab also found that you could drastically truncate the MECP2 protein, eliminate 80% of the protein, and just include the MBD and a portion of the transcriptional repressor domain. They call it the mini gene. That could, those animals, mutant animals that carry that mini gene, were near normal, and this thing could rescue the phenotype in a null mouse. And so that led to the development of the mini gene as one potential gene therapy agent, and then microRNA elements were included to regulate the problem of overexpression. So these are the two phase 2 clinical trials that are going on right now. One that's using this agent called TSHA 102 or TSHA 102. It's a self-complementary AAV. That means the package, it can only carry about 2 kb of DNA. It includes microRNA binding elements that have a feedback loop, keeping things under control and controlling overexpression. So this vector, at least in early studies, the outcome measures are regain or gain of developmental milestones, as well as the clinical global impression of improvement and a motor behavioral assessment, and results are promising. A second trial that's also ongoing right now is sponsored by Neurogene, and their product is called NGN-401. It's a different strategy, but they use a full-length human MECP2 cDNA, but is driven by a modified CMV enhancer chicken beta-actin promoter, and includes microRNA elements that are non-mammalian to regulate the overexpression problem. Again, early results are promising for both of these things. Now, lastly, let's see, I think I have 2 more minutes to tell you about what we have been doing for the last 5 years. In 2018, I read a paper written by Dr. Chatterjee on her discovery of a new clade type of AAV virus. These were isolated from human stem cells that they were harvesting from cancer patients at the City of Hope. And she discovered that this clade of AAVs mediated high efficiency, high fidelity gene editing using the traditional homologous recombination machinery of the cell. So when I saw this, I said, oh, great, this is the answer to all of my problems. We don't have to worry about including heterologous promoters or microRNA elements. We can retain all the control elements of the normal gene. So I finally talked her into helping me, and we designed an editing vector that would potentially correct all, more than 95% of the mutations. We tested these in patient-derived cells, fibroblast cell lines that we had maintained here, and showed that a single virus had the potential to correct all of these mutations. This was published already. And here it shows that, this panel shows that in a male cell, this is the male deletion cell, it actually restores expression of the protein, which is, again, to us earth-shattering that you could do this. The vector does not contain any promoter itself, so it's using the native elements to drive the protein expression. And the only way you can get a re-expression of protein is if the the homologous recombination editing event has actually occurred. We in our lab here at TGen, again with Sampath and Arvind, we tested this editing vector for exon 4 mutations using one very common model, the R306C. This is in the top 5 of the mutations in humans. And this is really unique because it is not a null model, but the point mutation completely disrupts the function of MECP2. That means the mutant protein is made in these mutant cells. It may occupy the methyl DNA binding sites, but it doesn't do its job. The effector component is gone. And we showed that by injecting the editing virus systemically, through an IV injection, we were able to rescue the survival problem. R306C die off just like the null mice. And we were able to rescue the phenotypic severity. And here it shows that at a certain time point, there's a dramatic difference between edited and unedited mice. Dr. Chatterjee has now got a new editing vector. We call it the universal editing vector that will take care of everything else, including deletions. And she has tested this in the same MECP2 knockout mice. And here, again, this is data from Dr. Chatterjee. This is a micrograph showing the untransduced null male. There's red staining would be MECP2. This is a wild type animal where MECP2 is in the nucleus. These are examples of edited male MECP2 mice showing that you can get re-expression of the protein in there. Now, with the R306C mouse, we cannot use antibodies because the antibodies will cross-react to the mutant protein. So I think I'm going to finish there. Just conclude by summarizing that over the last 20 years, work has led to one FDA-approved drug, that's trofinetide, the IGF pathway. 2 human gene therapy trials are currently underway. And something that we have been working on is still in a preclinical stage, MECP2 gene editing system using homologous recombination, where a single vector can treat more than 99% of all the mutations that cause Rett syndrome, high fidelity, high efficiency. And this can be used for practically any genetic disease, not just Rett syndrome. And we are testing it now in Usher type 2 cell models. So I'll stop there. I'm sorry I've gone a little bit late, and open to questions and discussion.
That was excellent from both of you. I really appreciate it. It is a wide-ranging improvement that we have, and so I'm glad to hear all the information. There is a question, looks like, from Dr. Kruer. You can unmute yourself if you want, Michael.
Yeah, fantastic talks, Terry and Vinod. I had a question, particularly in regard to the gene editing. Dr. Narayanan, if you could talk a little bit more about what the next steps are in that particular process, I'd be really interested to hear them.
Right. So that gene editing vector that we made, that we call the universal vector, it actually deletes the intron 3 that's between exon 3 and 4. We've just realized that there were no important elements in that intron. And by joining exon 3 and 4 together with what we call a codon-altered sequence, without changing the protein sequence, this forces recombination to occur outside of the exon 3, exon 4 area. So this, again, we have tested in male animals, and it seems to rescue phenotype and expression of MECP2. We have started the testing on females because that's the most important thing, to make sure it's not toxic in females. And I think with all the experience using AAV viruses, we know how to handle the immune responses and how to pre-treat human beings. I think going to human clinical trial will be probably 2 years away once we get all of the female studies done.
Great, thank you.
Yeah, and the other, as a corollary to that, the Usher 2A, that work started off because of a patient that came to see me in my clinic The USH2A gene is humongous. I mean, it's nearing the size of the DMD gene, and there's a recurrent mutation in exon 30 or 13 of the USH2A gene that causes retinitis pigmentosa and the biggest main cause of Usher type 2. But that the usual AAV strategies just will not work just because of the size of things. And so it seems ideal. And so we are working on, again, gene editing strategy just to take out, replace exon 13 mutation with a wild type exon 13. Again, very promising. We'll, again, a few years away from seeing that in human clinical trial. Yeah, I might mention one more thing.
Please, yes.
Before the gene was discovered, we were collecting, families. There were probably about 10 familial cases that were known, where a mother had a child who was affected, and some of them were, an auntie passing, and things like that. Just a handful. About everybody else was de novo. But there was one family from Brazil that Dr. Naidu invited up to Kennedy Krieger in Baltimore. This is a mom that had 4 affected children. 3 were alive, 1 had died away. And she told me about this, and I put her in. I connected her with Eric Hoffman, who was then at the Children's National Medical Center in D.C. Again, expert in gene mapping. And they use this family to really localize the gene to XQ28. So that was a real breakthrough because they had pretty much ruled out the entire X chromosome from consideration by exclusion mapping. But this was a key family, and then it was just a matter of slogging through the end of the X chromosome. And the Baylor program were sequencing the X chromosome anyway, so it was just a matter of time before they localized the gene. I mean, Dr. Naidu's work was very critical in identifying the gene.
Vinod, could I ask you how many adult patients you have?
Well, since I've been working here for over 20 years, many of my patients are now adults.
Right.
I would say about half of them are in their over 20. And probably, I mean, I can think of 5 or 6 of them off the top of my head, but probably more than that around here.
Okay, thank you.
You guys both highlight the importance of the collaboration. I mean, just knowing what's going on around the country and around the world. There's nothing that takes the place of that, and the research funding and the research dollars. So appreciate all you do. It's amazing. So
we have been Terry and I have been talking about Rett clinic at CRS for, I don't know, at least 50
ages.
years. Ages. It never happened. So I'm just really, really happy to see that Terry and Dr. Angapan are planning this, and I think it's just wonderful. I think this is how it should go, because you'd be ready for all the clinical trials that are coming down the pipe.
Yep, exactly.
Good.
I appreciate you guys. Thank you so much.
Thank you.
There's a lot of good comments in there. No other questions, but just, everybody's very excited to be able to provide this here, and maybe they don't have to go to Colorado.
Hope not.
Yeah, exactly. You guys have a good rest of your Monday. Thank you, everybody. And if anybody who's still on, if you didn't see the text, that I think there's the CME system is down, so as long as everybody's names are in there, or if they just reach out. So